We're going to get started, so please try to find a seat or stand. Thank you. Okay, we're going to get started. So firstly, I'm Wafaa El-Sadr. I'm director of ICAP and director of the Global Health Initiative here at the Mailman School of Public Health. And it's a great pleasure to welcome you today to this World AIDS Day event. We are thrilled that you're here to join us to discuss and talk about HIV and Ebola, fear versus evidence. And we have a terrific group of panelists who are joining us today to help us in highlighting some of the issues today. But before we get started, I'd like to invite Dean Linda Fried, who's going to give a few words of welcome for everyone here. Welcome.
Well, good afternoon, and it is my pleasure as well as honor to be able to join in welcoming everybody here today in recognition of World AIDS Day, and to welcome our distinguished panel of experts and thought leaders to the Mailman School for what I know is going to be a very substantive discussion. So thank you for joining us and leading us today. Through ICAP, and the whole host of other faculty and students in the school and among diverse programs throughout the school that have worked on HIV/AIDS since the inception of the epidemic in 1981. This school has had a deep commitment to every layer of how we bring evidence to public health solutions around critical issues for population health. And of course, today's event in recognition of World AIDS Day is consistent with that commitment. And while it's a moment in time in the journey, I believe that it marks a very important moment, which is not just to observe how much has happened in regard to prevention and care of HIV/AIDS since 1981. How it has transitioned in the context of the availability of treatment and the availability of the right health systems to a chronic disease, but also in recognition that we have learned so much and accomplished so much through public health leadership and in partnership with all sectors, that we are now in a position to reflect on the learnings from HIV/AIDS as well and use that to inform decision-making and action around emerging or re-emerging diseases such as Ebola. And so it's just an interesting moment for me to reflect on the journey of HIV/AIDS since 1981. And where we are now. And of course, the critical issue, I think, is how to anchor decision-making based on both evidence and experience, which is our responsibility in public health, how to take a frame to protect people at the level of populations as well as at the level of individuals, and to lead from science, evidence, and experience at every point, to be equitable, to be just, and to accomplish the outcomes we need. So with that background, it's my pleasure to, again, welcome everybody, to thank our panel for being here. Wafaa, thank you for convening World AIDS Day, as you do each year. I deeply appreciate it, and thank this wonderful audience for being part of the discussion that's going to ensue.
Thank you very much, Dean Fried. And I'm going to start by just showing and going through a very brief presentation to try and frame the discussion for all of us today. So today we are really talking about HIV and Ebola, and we call this presentation A Tale of Two Viruses. So just to, what do we know and what's the magnitude of both epidemics? I think it's really important on World AIDS Day to recognize the magnitude of the impact of the HIV epidemic on the lives of many millions of people around the world. And as you can see from this slide, it's estimated based on the latest estimates, there up to the end of 2013, there are currently 35 million people living with HIV globally. Just in 1 year, in 2013, there were 2.1 million new infections, new HIV infections. And then there were also, during that same year, there were 1.5 million deaths from HIV. So obviously this is an enormous epidemic that continues. I think somebody else is dealing with the connection with Sheri. That continues to impact on us here in the United States as well as globally. Now, if you contrast that with the Ebola outbreak that's ongoing now in certain countries in West Africa, we know that to date there are about 15,000, almost 16,000 cases of Ebola that have been reported. And out of those, there have been getting close to 6,000 deaths related to Ebola. So although the magnitude of the impact, of course, is quite different between the HIV impact, the global HIV impact, and the very focal Ebola impact, nonetheless, both are quite important outbreaks, epidemics that we have to deal with. Now, there are some similarities and there are some differences between the two viruses and the two conditions. Let's start first in the middle there with the similarities. Of course, obviously, both are caused by viruses. They spread through blood and other bodily fluids. Both have high fatality rates if they're not treated. There's no approved vaccine for either HIV or for Ebola. Both viruses are known to have originated in Africa. And we also recognize that for both, action by international community is very critical to controlling the spread and also care for those who are affected. On the other hand, there are distinct differences between HIV and Ebola. The virus HIV, which causes AIDS, has a long latency, a long incubation period that can vary from long asymptomatic periods of months, even years, many years. And symptoms need not be present for a person to be contagious, and that's a very important difference between HIV and Ebola. Patients can unknowingly spread HIV to others because they are very often very asymptomatic for many years. And there's low visibility because symptoms only appear very late in the disease. And finally, of course, HIV kills the individual if untreated, largely indirectly through affecting and weakening the immune system. On the other hand, Ebola has a relatively short incubation period from 2 to 21 days. Symptoms need to be present for the patient to be infectious to others. And as symptomatic, it's easier to know who's spreading the infection because it's spread from someone who has symptoms. It's very highly visible, severe symptoms, and easily and quickly visible. And finally, that the virus kills the individual who is infected by causing direct damage, dehydration, hemorrhaging, and subsequent organ failure. And we know that we have, obviously, treatment for HIV, and there are no known effective treatments for Ebola, and there are no vaccine for either of them. So let's start with the fear. As many of you, and our session today is about fear versus evidence. As many of you have been quite noted that in the media, and this is from the New York Times, actually in October, that there certainly is fear and stigma now of healthcare workers who are involved in the Ebola response. This is one headline from the New York Times of Bellevue employees who face Ebola at work are stigmatized everywhere else. This demonstrates, again, the fear that's prevailing in the community. And this is, of course, the whole other issue around quarantine. And as you know, the story of the quarantine imposed on the nurse who came back from working in West Africa, and the other imposition of quarantines on other people who have returned from those countries despite the lack of evidence to support such action. We'll have the opportunity to discuss this today with our panelists. However, we also know we have a lot to learn from history. And the history of HIV, there's also obviously been fear and stigma. And I couldn't help but putting this statement here by William Buckley from 1986, that he actually at that time advocated that everyone detected with AIDS should be tattooed, believe it or not. It's hard to imagine that this was a prevailing, or at least one person's opinion. I think, on the other hand, there remains substantial stigma. 78 countries worldwide list homosexuality as a crime. Criminalization of key populations, 60% of countries. This is, of course, hindered effective response to the epidemic. Studies show there are breaches of confidentiality about healthcare workers in many countries. In China, the national policy actually disqualifies people with HIV from employment. And we all know that in 2011, an LGBT rights activist in Uganda, David Kato, was actually killed for his advocacy. And lastly, there have been discrimination against various, in schools, against young people who happen to be living with HIV. So what will it take to control Ebola outbreak? What are the needs and challenges and opportunities? I think in essence, it's quite simple, but it's quite difficult. Obviously, we have to have a case definition. We have to find the people who are affected by the disease, diagnose them with Ebola, isolate the cases, do the case diagnosis and management, do contact tracing, finding the contacts of these symptomatic individuals, monitor the contacts, isolate the ill contacts, and so on and so forth. And behind these simple, very simple, what seem to be simple activities, there's the need for a whole other structure, the health system structure, to enable this to happen. How do you find people? How do you diagnose people? Who does it? How do they do it? How are they supported? Do they have the equipment they need? Are they able to do it? So what are some lessons learned from HIV that may be applicable to Ebola? Obviously, advances in HIV research have really enhanced the care, treatment, and prevention, and there's encouraging work now on experimental vaccines that look like might be promising, experimental treatments that appear to be promising as well. We do know that optimizing HIV prevention, care, treatment, and support by strengthening health system is what enabled the HIV, the successful global HIV response. And I'll tell you a little bit about what we mean by strengthening health systems. And I think another important lessons learned from HIV is the importance of community engagement and responsiveness, and engaging the community affected individuals to define the needs of people living with HIV and their families and their communities, as well as to shape the response. So what has been some of the response, and these are just some bullets, and you probably can't read many of them, but this is from our own response, our own work at ICAP, and I think there are certain principles that should apply to the Ebola response. The need for partnership with ministries of health, the need for non-governmental organizations, with academic institutions, with community-based organizations, so that they can shape a multi-sectoral approach. The need for training, skills building of the healthcare workers at all levels, so they can actually do what they need to do with confidence while we're protecting them from the infection. The need to develop novel models of prevention, care, support, and so on, so that actually the work can be done. They need to strengthen the managerial, administrative, financial systems so that the response can be efficient and effective. The need for infrastructure response to be able to enable facilities where people can be taken care of, as well as laboratories and turnaround time for laboratory diagnostics. The need for procurement of supplies, equipment, and medications. The importance of engaging the patients themselves through education, counseling, and outreach. And developing, of course, measuring through monitoring and evaluation so that we know what we're doing and how we're doing. And lastly, very importantly, of course, the need to garner the engagement of the communities themselves. This is what's been done in the global HIV response, and it's quite relevant to us that this is very relevant to informing the Ebola response as well, and should inform the Ebola response. So on this day, or actually 2 days ago with World AIDS Day, and these are the numbers that I told you about, and I think it's really important to not forget that we have a long way to go in terms of vanquishing the HIV epidemic. While a lot of progress has been made, it's estimated that, as you can see from this slide here, that about 60% of people, even who need treatment for HIV now, do not have access to treatment. And as I mentioned to you, 2.1 million new infections are occurring. So we can't be lulled into complacency that we finished the business of taking care of HIV. There are new infections occurring right here in the city, in New York. There are new infections happening everywhere. And we need to be vigilant in order to be able to confront this epidemic and not be lulled into complacency. I think, on the other hand, we also need to be very cognizant of the issues related to Ebola. This is a survey, Gallup poll, that asks people what are the most important health problems that you're facing. These are people in the United States. And believe it or not, the third issue was Ebola. So it's kind of makes you wonder, but I thought it's intriguing to show it. Number one was affordable health care and health insurance. So that's really good, right? Number two, with access to health care, universal health coverage, that's really very good as well. Number three was the Ebola virus. So we have a long way to go to do what public health does, right? And to inform the population and to get these priorities right. If you go down the list, way down there is AIDS. 1% of people indicated that was a priority. So we have a long way to go, both in terms of addressing HIV, as well as, of course, appropriately addressing the Ebola crisis. And I think in addition to the fear of complacency in terms of response to HIV, I also fear there's going to be complacency in terms of addressing the Ebola outbreak in West Africa. And you can see here that this is, again, how the Ebola outbreak compares and other selected public health stories that people are following. And 50% of the sample says they're really following very closely the Ebola response. So that's encouraging, and these are people in the United States. However, when we look at, and again, unfortunately, you probably cannot see this, but these are the numbers of stories every month regarding Ebola in the New York Times, and you can see the peak here in October. That was at the time when we had case here in the city. And again, you can see there's a decrease that followed in the numbers of stories about Ebola. So I think there's also a similar concern in terms of lulling the people in this country and the people who are hopefully supportive of the response in West Africa, is that somehow people will feel it's not a problem anymore because it doesn't come to our front door, and they will lose track of the fact that the epidemic, the outbreak continues in West Africa. So we need to keep people aware that we're not done with confronting HIV or confronting the Ebola outbreak in West Africa. And lastly, I want to end with this one slide, which I think I'm putting up particularly for Gregg and others, is that it's really important to acknowledge the value of speaking out and speaking up, and whether it be the activist in the HIV epidemic years ago or the Ebola activists now, is that these are individuals that included not just advocacy, but students of public health and other students and many others who were very much about evidence. It was not about emotions, it was about evidence, and demanding that evidence be at the core of the response to the HIV epidemic, and are now demanding that the evidence also be at the core of the Ebola response. So that's the end of my few slides, just framing slides. And what I'm going to do now is introduce our first speaker, right? Yes, so we have several people who are going to be part of our panel. One of our panelists, Sheri Fink, is in Geneva, and she's going to be joining us for a few minutes, and I'll tell you a little bit about her and then engage her with a few questions, and then I'll go back and introduce. She can only be with us for a few minutes, and then I can introduce the rest of the panelists. So just very briefly, Sheri Fink is a correspondent for the New York Times who reports on health, medicine, and science. And most recently, she's reported on the Ebola outbreak from Liberia. She has received the Pulitzer Prize for investigative reporting for her article describing the disturbing effects of Hurricane Katrina on a hospital in New Orleans. That article was published in the New York Times Magazine, and she was also awarded the National Book Critics Circle Award for 5 days at Memorial, Life and Death in a Storm-Ravaged Hospital, an account of what happened at this same hospital. Just to give you a little bit of Sheri's background, she received her medical degree and a PhD from Stanford University. After graduating from medical school, she decided that she wanted to be engaged in humanitarian aid work, and worked in many different areas around the world, including Kosovo, Haiti, Iraq, Bosnia, Macedonia, and Mozambique. She's written on a variety of different topics of public health importance, including the HIV epidemic, and most recently, she's been reporting on Ebola, as I mentioned. So thank you, Sheri, I hope you can hear me, for joining us from Geneva today, and thank you for your enormous contributions through your reporting from the field. Yes, we can, but we're going to try to make it even louder.
Okay.
So I think we have a few questions for you. And the first question we have for you, Sheri, is that you've been reporting on the outbreak from West Africa and giving the audiences here in the United States and globally just a glimpse of what's happening on the ground. I think we're curious as to the role of the media within the affected countries themselves, the role of the media in Liberia, in Sierra Leone, and have you noted, that it's been supportive? Has it been largely, highlighting the evidence versus highlighting the fears? What has been the local media doing in Liberia, for example?
Well, I think the media role, obviously, is one of the tools, certainly, that the responders are using to try to get messages out to the public. And in a lot of places, radio is a major way that people get news. So there's been, I think, the local radio stations have given a lot of time over to the responders, to the people who are working in the public health field to try to get those messages across. There are often call-in radio shows, and there have been radio dramas, so that's been a big tool. And then, of course, for people who do read, and for the newspapers, for the larger towns and cities, Ebola is a constant topic, and the reading that I did when I was there, I found it quite informative. And of course, there's sort of a mixture of different types of stories. Information seemed to be pretty solid from a public health standpoint. I mean, maybe some of the editorials that I read veered off a little bit, but at least at this point, this many months into things, I'm seeing pretty good use of the media. But I can't say that I did an exhaustive study of it. I do think it's a very important part of the whole effort.
Great, thank you. Another question, I have a couple of questions, and I know you have to run. But we're wondering here, since the theme is HIV and Ebola and the connections, similarities and differences, are people on the ground in Liberia, for example, are they at all making that connection in terms of the response to Ebola?
I have heard that talked about, and the most recent example was actually somebody who's been involved for many years in Ebola outbreaks for the World Health Organization, and he just happened to bring it up in an interview yesterday, just talking about how many parallels he sees. But we certainly see, and I missed most of your intro, so apologies if this is repetitive, but just the kinds of huge stigmatization of people with Ebola, of people associated in any way, people who test negative, but who have gone to a treatment center when they go home. So there's a lot of focus with the response on reintegration. Certainly when I was at one Ebola treatment unit for several weeks, just kind of following the stories, there was always an effort when somebody went home in whatever way they were discharged. Either they had tested negative or they had come out and been cured, had recovered. They would go home with somebody who would then reintroduce them to the community and try to ensure that they had a smooth transition. And then you see communities now, in an effort to protect themselves, taking a lot of very drastic measures and doing their own kinds of quarantining, very localized. As communities get more aware of Ebola, they're taking, keeping a very close eye on who's coming, who's going, and who may be associated with a case of Ebola. So, maybe some of those measures would seem a little drastic and could also contribute to people going underground, people wanting to hide the fact that they have, a loved one who's sick or somebody who has died in the family. So that is a constant effort right now to really, balance the public health measures with the awareness, with the, I think knowledge is really, really key. And we see in the US there was this period where there was so much fear and panic and overreaction and sort of an unscientific response. So it's, same with HIV. It's really a lot about the media, about mass media, about getting the information out there in whatever way possible so that people are informed. And I think that's really the antidote to fear and the antidote to panic and overreaction.
Thank you. And lastly, I think the last question, I know you have to go, is we've heard that people who have other health conditions are afraid to go and seek care because of the fear of acquiring Ebola at health facilities, as well as probably because there are fewer healthcare workers at those facilities. And we're just wondering, again, in terms of just the magnitude of other health problems that are very prominent in these settings, what are you seeing on the ground, and what's being done to try to make people more comfortable to come back to utilize the health system?
Well, it's a reasonable fear. The health facilities were sometimes amplifiers of Ebola, and that was when health facilities are not prepared, when health workers aren't prepared, when they don't have PPE, when they don't have training, when they don't even have water and soap to wash their hands, then it becomes a dangerous place both for the health workers and for any patient who comes in. So it was sort of a reasonable thing that some of these places closed down, and now there definitely is amongst responders a recognition that this is a key priority, and it's really tied into ending Ebola as well. You just need these health systems to come back, but there's all sorts of obstacles to doing that, from everything from protective equipment sitting in warehouses while it takes weeks to work out memoranda of understanding. This was a frustration that an NGO recently said to me, but you can be assured that the people who are doing the response do realize that it's a key priority. And I saw it firsthand. Sometimes, for example, if health workers don't feel comfortable in dealing with a patient, and you see this a lot with pregnant women who are bleeding. Any pregnant woman who's bleeding is considered a possible Ebola case and has to go through a process of being ruled negative before somebody will treat her. And there was a lady who had a ruptured ectopic, who basically just was in pain for day after day until finally she could be moved from this place to that place and get the test and get cleared, and then convince people at a partially functioning hospital to take her in, and her story ended with she did get the surgery that she needed, but it was just because of the heroic efforts of a lot of people, and there's got to be a lot of people who aren't getting the care that they need. So this is really, really important.
And we actually saw when we heard about in Sierra Leone of a young man who was suspected of having Ebola but had appendicitis. And the same issue is that they're waiting to rule out Ebola before they could do the surgery, which again highlights the importance of the health system, the diagnostics, and that everything has to happen in a very efficient way, which unfortunately is not always available. I know your time is tight, so I want to thank you for being with us, and please continue to do the great work that you're doing and the great writing.
Thanks for the work that you're doing, and I'm so glad that everyone's engaged in this topic. It's really very timely and important, and I greet you all from afar.
Thank you.
Thanks.
Great. Okay. So I think we'll continue now with the rest of our panelists. So I'm going to take a few minutes to introduce them. We're very fortunate to have quite an amazing group of individuals today. So I'm going to start with introducing Emmanuel Darcourt. Emmanuel, just say hi to everybody. So Emmanuel is currently Senior Health Director for the International Rescue Committee, IRC. And he heads a team of public health professionals, provide technical assistance to IRC's work overseas, including environmental health, primary health care, and many, many other issues in Africa, Asia, the Middle East, and elsewhere. His work has really focused on improving the health of children and women in the countries affected by conflict. He received his medical degree from Johns Hopkins, MPH from Harvard School of Public Health, and is a pediatrician by training. IRC has been at the forefront, certainly in Sierra Leone, where I had the opportunity to meet with the team on the ground. They've been very involved in the fight against Ebola virus since the very first cases were identified, and they're really doing amazing mix of work in terms of training, education, surveillance, many other activities right there on the ground. Next to Emmanuel is Gregg Gonsalves, and Gregg is the co-director of the Yale Global Health Justice Partnership, an initiative of Yale's law and public health schools. Focuses on teaching, research, and policy at the interface of health, medicine, law, and human rights. He is also a PhD candidate at Yale School of Public Health. Now, I've known Gregg for many years. More than 2 decades. He's been an AIDS activist for more than 20 years, worked domestically first on the AIDS response here in this country, and he focuses attention actually on really challenging the National Institutes of Health, the Food and Drug Administration, and many other entities, including pharmaceutical industry, pushing all the time to push them to do what needs to be done. He's always been one of those individuals that is always willing to stand up for what's right, to tell it as it is, and he's always anchored all of his actions in evidence. So we're very happy to have you here, Gregg, with us. Thank you. And then we move next to Imam Soleiman Konate. And Imam Konate was born and raised in Côte d'Ivoire. He studied Arabic from his father, who was also an Imam. He studied Islamic law in Egypt at Al-Azhar University in Cairo. That's my own hometown. So welcome. Ahlan wa sahlan. And then he studied communications in Saudi Arabia, where he lived for 12 years and worked as a reporter, actually covering West Africa for Saudi news publications. In 1992, he moved to New York City, aiming to furthering his education. Since his arrival in New York, he has provided leadership in convening the West African community to address health issues, including HIV, hepatitis, and now Ebola. He has generously served as a media spokesperson for a Harlem-based African HIV anti-stigma campaign, which ran for several years. And he's been a bridge builder. He's figured very prominently in creating channels of communication between the African community in New York City and governmental and non-governmental organizations. So thank you very much. Ahlan wa sahlan. And last but not least, Jay Varma. And Jay is Deputy Commissioner for Disease Control in the City of New York. And he directs the Public Health Laboratory and all infectious disease control activities for New York City, including HIV, TB, other sexually transmitted infections, vaccine-preventable diseases, and now Ebola as well. He's prior to joining the New York City Department of Health, he spent several years at CDC in a variety of different positions as a medical epidemiologist, including working in China, leading the International Emerging Infections Program in Beijing, and he also worked as director of the TB Asia Regional Program as well. And together with Commissioner Mary Bassett and others at New York City Department of Health, they have been a voice of reason in the midst of the madness. And we're very proud to have the Department of Health, like the New York City Department of Health, that is truly anchored in evidence. So thank you all, and welcome to this discussion. Okay, maybe we can. Okay, so what I'd like to do is to ask a couple of questions, and I want to get your questions. I think what we want to do is engage in a conversation, okay, around the core of today's topic area. So maybe I'll start with a question for you, Emmanuel. And I'm wondering, in terms of the IRC response on the ground, what are the kind of differences that you note between the Ebola and the HIV, key differences and some similarities that you're keeping in mind as you're guiding your teams on the ground in both Liberia and Sierra Leone?
So we're seeing many differences. It's important to note that, of course, we're seeing the HIV epidemic at a very different time from where we're seeing the Ebola epidemic. I suspect there would have been more similarities if we were talking about 25 or 30 years ago, because then some of the wild gap between the reality and how people perceived it was very strong. I remember my father saying, that he didn't use public toilets anymore in the early 80s because, he's not a particularly public health-oriented person, but that was the kind of prevailing thought. So I think there would have been more similarities. But now we see, there are huge differences. Some that are based in reality, and you highlighted some of them. I think there are some important biological differences which have really huge implications for the response. The fact that you're with HIV, you're very much you could be infectious without being symptomatic, whereas with Ebola you don't. That's a huge that and a couple of other features really are a huge difference that make Ebola in many ways easier to contain. The HIV is quite difficult, and we do treatment for HIV, we do some prevention activities, but we really don't have any hopes of wiping out HIV, whereas we have every hope of wiping out Ebola in West Africa. It's feasible, I think it will be done, even if, I think it's likely that a vaccine will come on board and be effective, but even without a vaccine. So we have kind of a different objective in the sense that Ebola is, as paradoxical as it may seem right now, is easier to fight than HIV. What's quite different also, so that's a real difference between them. We're also facing the difference in image or thought about it. And with HIV, as we saw, with the list of priorities, it's kind of essentially under the radar. If I come back from Africa, nobody ever asked me if I have been in contact with an AIDS patient or something like that, which again, 30 years ago, I bet you people might have asked that question. Whereas in fact we spend a huge amount of time and energy figuring out how to deal with the multiple issues of people returning now from going, whether they're somebody who's given a choice between not seeing their kids for another 3 weeks or having their kids be out of school, or somebody whose landlord told them don't think about going back to the apartment forever, not even for 3 weeks, but in any case absurd. So we face a lot more attention for Ebola, but there's a good side to it, as unmerited as it may be. The reality for anyone who's worked with HIV in Africa, as I suspect in this country, is that you can't do any of this work without seeing the glaring political and social sort of inequities and bad things that underlie the disease. And with HIV, I think paradoxically, and I'd be curious to hear from Gregg on this, that it's kind of gone away, that people are back to kind of a technical view of it. It's a disease that needs to be treated, and people aren't thinking so much about how you get it. Whereas with Ebola, I think we have a window of time where everybody is talking about health systems. I have thoughts about that. I think some of that talk is a little, I think there's problems with some of that talk, but generally it's good that people aren't looking at it and saying, at least maybe we're in a bubble, but a lot of people are saying Ebola isn't coming from nowhere. Ebola is linked to other problems in society. It's certainly linked to health systems, and we have to deal with that, which we don't get as much about for HIV. So I think it's a disease of the moment. It's got a lot more attention than HIV. There are problems with that, but it's also an opportunity to be frank.
Okay, maybe we should move on to Gregg, and you particularly have been actively involved in some of the controversial issues in this country in terms of the threats of quarantines by certain political leaders and public health leaders, actually. And you and other AIDS activists did write a very important piece, letter to the governor, and also a very important piece in the England Journal of Medicine about the issue of mandatory quarantine and so on. So what motivated you and your colleagues to do this?
So, as I look around this room, I see people who've been doing AIDS work for 20 plus years, and I think they understand very well why AIDS activists got engaged in this issue. Back then it was the 4 H's, and it was Haitians, homosexuals, heroin users, and hemophiliacs. Right? CDC decided that we were spreaders of disease, we were disease vectors, and there are all these discussions about quarantine, about tattooing. Remember Ryan White, remember yes. The Ray brothers who were thrown out of school? Well, 30 years later, it's West Africans, it's healthcare workers, it's a whole set of other people who are being stigmatized without very much evidence at all. And so in Connecticut, where I live, it got very real. Two of my friends at Yale in my very own PhD program were quarantined for 21 days, and 7 others were put under strict quarantine. This means no visitors, no human contact for 21 days, based on no evidence whatsoever. And so we don't have an Ebola epidemic in the United States, but we have an Ebola panic, right? Or pre-election day we did, right? But it really set off alarm bells for all of us in terms of how we react to public health crises in the US. If this was a test case for what people are going to do in the context of a very scary new epidemic, we are in big trouble. So, you know, I mentioned this to Wafaa and to Dean Freed coming when I got in. Columbia University, for instance, has a policy that if you've come back from West Africa over the past 21 days, do not think of coming to campus. Wafaa broke the rules, but the point is that...
Because she's anchored in evidence.
But all of you have to write to the president of the university. Why is there a policy at Columbia University and other universities around this country that have a mission for research, teaching, and evidence, saying that for 21 days you are a danger to the academic community? It's just insane. And so all of this is happening, and you know, New York City has been a breath of fresh air in terms of the municipal response, and Commissioner Bassett and Jay and others. But Connecticut has done terrible things and are not very interested in listening to reason. Think of the other jurisdictions around the country that are doing some of these things. People are starting to backtrack a little bit, but we were on the phone with some civil rights attorneys yesterday in Iowa, in California, in places where you don't think this is happening. Healthcare workers are worried about what's going on and whether they should even go with IRC or MSF or others to volunteer. We have to address this now. There's a lull. Wait until the next case comes, Ebola case emerges from overseas in the U.S., and there's going to be another cycle of panic, and more people are going to get locked up. It astounds me that not more people have gotten involved in this. You know, the demonstration that Wafaa showed in those pictures, those are old ACT-UP people, some new ACT-UP people, but a lot of old ACT-UP people. Why is it the AIDS activists who see these fault lines emerging about how we deal with disease in this country? And one last point, talk to Emmanuel's question, we didn't have to have the Ebola epidemic. We didn't have to have the HIV epidemic. We didn't have to have the MDR-TB epidemic. All these were manufactured public health crises that could have been avoided if we'd invested in health systems, if the Reagan administration had reacted to the disease early on, if we had decent TB control programs around the world. And so I think that these activists do see the politics embedded in all of these health crises. I do think maybe over the past decade or so we've gotten very technical in our responses, and even NGOs have decided they have to work with the Global Fund or UNAIDS or PEPFAR and do very technical pieces of work. But very few people are out on the streets as they were 30 years ago when again, we're on a university campus. We know that half of young gay men, by the time they're 50, by the time they're 40, are going to be HIV positive. And if you're a black heterosexual men, have even a higher rate of chance of being HIV positive by the time they're 40. And so if that's not a crisis that approximates what we saw in the beginning of the epidemic, or is even worse, and is worth getting out on the streets about, I don't know what is. So I think Ebola just sort of set up a bunch of reactions in all of us who worked on HIV to say, here we go again, and we can't let it happen this time.
Thank you. Thank you. Thank you. Move on to Imam Konate. I think it would, the impact of the Ebola outbreak on the West African community in New York must be very profound. And I'm wondering if you can share with us sort of how the community is dealing with this and how you are trying to guide the community.
Thank you. Forgive my language, because I am comfortable if I speak in Jula, Arabic, or French. My English is not good. I didn't go to school for the language, so please forgive me. I might speak with the accent. So, thank you for inviting me. I was the first of few leaders and imams in African community to speak about HIV/AIDS. Because we all know that if you mention HIV/AIDS in African community or Muslim community because for them is related to sex. And sex in our community is taboo. So the first day I mentioned HIV/AIDS and protection by using condoms. Many people of my congregation thought that I was crazy and I was losing my mind. But we are so grateful that finally they got the message. So when we come to Ebola, we are mobilizing people, the members of the community, because Ebola is a reality. Ebola is there. It's killing people, not only regular people. Even I know some imams who died by Ebola. The second imam, the vice imam in Guinea, passed away by Ebola. Why? Because when the imam passed away, the vice imam took responsibility to watch the body. That's how he got, he got infected with Ebola and he passed away also. So the reality is there. So what we're doing now is we are organizing town hall meetings. We are praying, reciting Qurans, mobilizing the imams to pray because the supplication, because we don't know yet. We are talking about vaccines, but before we get the vaccines, we must supplicate ourselves to Almighty, the Most High. So therefore, the problem today in African community in general is stigmatization. Really. Even myself, I was a victim of stigmatization. How? We were invited to meet with Ambassador Antonio, Titi Antonio, the Ambassador of African Union at United Nations. After the meeting, so I went to the train station to take my train, go back to the Masjid. So few people around myself, because the two of my clothes, they found out that I'm African. When you are African today in New York, I don't know, Newark, New Jersey, everywhere, especially Staten Island, because when you go to Staten Island, you find yourself like you are somewhere in Morovia because of Liberian population. That's true. So they start covering their nose and their faces because of myself. They see me as the man who brought Ebola to America. It's almost now 5 years I didn't go to Africa, but they don't even know that. You know, our children now, they have been beating in schools because, you know, and they were born in America, the citizen of America. So this is the Newark area, Newark, New Jersey. Some of the kids also in school, they were beaten by their friends, by their colleagues, because they're from Africa, they call them Ebola. So that's the problem. Even the sisters who are doing the hair braidings, their business went down. Because today, if somebody decides to go there to fix their hair, oh, you are going to Ebola now? So now the business is done. Even the taxi cab drivers, they don't make enough money right now because they're from Africa. So we need to stop that. Some of these people, almost 15 years, 25 years, they didn't see Africa. They know Africa through the television or phone calls. That's it. So we know Ebola, but I think the problem is the press, the media. The media loves so much negativities. Their major focus is at negativity. So that's it. In Africa, we're doing a lot of things which is good, but they don't talk about that. HIV is a blood virus. Ebola is an African. What about Congo? What about Congo? Because they found out Ebola in Congo before Guinea and Liberia and Sierra Leone. What about Congo? my last, I will close by sharing this with you. We close in our meeting with Ambassador Titi. Some of the media people were there. They asked me a question, a specific question. They asked me, Imam, do you know the source of Ebola? Where Ebola is from? Is the man who made it Ebola or Almighty? That was it. And I'm sitting there, I don't know what to say. But finally, I respond to them that the day God decided to send Adam and Eve, whatever sickness they found it here, there were medicine for that. But anything with no medicine is made by man. That's why we don't have no medicine to those things, HIV and Ebola. It must be made by man. If it's by God, believe me, God will provide us a message with a medicine to cure them. Thank you.
Thank you. Let me move on to Jay. Whenever I'm listening to the radio and I hear Jay answering questions, I'm always really heartened to hear your voice because it's such a sound of reason. But I'm just curious in terms of how have you been able to deal with the onslaught of the media, and in particular at a time when the interest in negative stories, the demand by the media for certainty. You have to be certain. There cannot be any doubt. You have to be absolutely 100% sure of what you're saying. You can't change your mind. How do you balance this when you're in a leadership position in public health?
Yeah, thank you very much. I think that we've definitely had an interesting experience with an outbreak. I mean, I've worked on outbreaks all over the world. But this was certainly the most challenging because it involved an outbreak of fear, which, as we've sort of come to realize, is as dangerous and as contagious as any virus that exists. And so really very early on, we knew that we had to do as much as we can in terms of communicating with populations at risk, with the general community, using every instrument we had available to us. So that included working with people like the Imam and other people in the West African community, and that included doing a lot of media appearances. I probably did more in the past 2 months than I ever have in my life combined. Just simply the sheer volume of newspaper, radio, television, web broadcasts that my wife Mary and I did. And one of the reasons we did that is we wanted to really get people to understand that this is a problem that we have very clear solutions to. As we heard early on, Ebola is actually not that difficult to control. In terms of the methods that are used, the problem is our health systems aren't adapted to them. That we wanted to make people understand that this is something we have thought through and it's something that we apply. Case finding, contact tracing, identification and isolation are things that we do every day for meningitis, for measles, for sexually transmitted diseases. So we wanted people to know the facts behind it, the tools that we have, the preparation that we had done, and we tried hard to make sure that people understood that message. I think obviously it's very challenging because as we know, there's an interest in finding something that goes wrong. So what was really probably more worrisome for us was not that run-up, because we felt that we were consistently communicating our message, and if we couldn't get that message across, there probably wasn't more that we could do. What was more worrisome for us is that when we actually finally did have a case in New York, our fear that something would go wrong. And to be very honest, we had an incredibly enormous response. We had over 400 or 500 of our own staff just at the health department alone. That doesn't count all the other city agencies. And really millions of dollars spent to control one case. But the reason we did all that was because we knew that we weren't just solving or trying to address one case. We were trying to address the fear in the community and also the lack of faith in government that had sort of been created by the missteps in Texas. So really that investment was as much about curing one person and preventing onward transmission as it was about curing a much more dangerous problem, which is distrust of government, which is really, I think, what perpetuates what's going on in West Africa right now.
Thank you. Thank you very much. I'm going to open it to questions, please, from the audience. We'll take a few questions and then we'll go back to the panelists. So, yes. If people would introduce themselves and then...
I don't have a question. Sorry. I'm Asif Patel, and I did public health from CUNY, and I did medicine from India. I don't have a question, but I have some comments.
Brief, right?
Yeah, brief, yeah.
Yeah.
First thing is that New York Department of Health has really done a commendable work, and I hope they get some award from United Nations. Yeah.
Hey.
And second thing, I would like to also recognize the work from CDC, because President Reagan administration took 6 years to acknowledge HIV, but Ebola was handled very well.
Thank you. Thank you. Yes, please introduce yourself, Kim.
Hi, I'm Kim Nichols from African Services Committee here in New York. One thing that I haven't heard very much about in this discussion, or many of the discussions, has been the lack of, or the presence of, partnership between governments in the 3 countries and community health workers, community health systems. We know, we've heard again and again from the field that there needs to be massive injections of support in community health worker response. Yet, we're not hearing that echoed by government in those countries. So what really is the situation? Maybe someone who's been there recently can address that more specifically.
Sure. Emmanuel, do you want to tackle this briefly here?
Thank you. It's a good question. I'll give you a somewhat counterintuitive response. I would challenge some of the assumptions. I think there's been a pretty good, not perfect, but pretty good connection between community health workers and the government. But I think the problem is exactly as Jay stated, the wider issue between people and governments. Because the community health workers have their role, and IRC works with tens of thousands of them. It's a major pillar of our work, so I don't dispute that they're a great tool in public health. But it's not the same as reaching the influencers in the community. And as our CEO, David Mailman, when we were explaining the situation, he said, what you're talking about is community organizers. And there's a subtle difference there, because I think what's needed and what's sorely missing is that people do not believe their governments. And it's possible that there have been community health workers. Sierra Leone has a very large-scale community health worker program. Liberia has a somewhat less successful one, but still pretty big. They're not the answer to getting community trust, because they're not necessarily leaders in their community. So I think what the key thing is not so much focusing on the health system, and again, not that the health system isn't important, but looking at the root issue, which is the government. So, people like Imam Konate or others, in a way, are more important than community health workers in a crisis like this, because you're talking about some pretty basic behaviors in some cases, and you're talking, in the forests of Guinea, the government has almost openly told people, you're on your own for the last 30 years. And suddenly now people in spacesuits are showing up, and they're expected to be trusted and believed. And community health workers aren't the answer to that basic problem. The answer to that basic problem is community organizing, which means finding who the real influences are, finding ways to approach them, and doing it. We've seen, for example, there was a great case, a guy who works with us, who works for one of our partners, who almost got killed going to another village, which spoke the same language. But when he went to his own village, he was welcomed as a savior. People were saying, we're so confused, we don't know who to trust. So you need to find in villages who are the people who really matter. And we know because the same thing happens in our communities. But it's a different art, and often, those of us who work on health systems, like, ICAP and others, we're used to looking at kind of the technical. We go to the health center manager, and then we go to the community health worker. But really, we need to find that person in the village who really wields power, and that's a little different.
Yeah, thank you. And certainly when we were, Susan Strasser and myself were in Sierra Leone, we did see very active involvement by community health workers. Many of them have been retooled to become surveillance officers and contact tracers. So they're playing a very critical role. But we did also hear the same challenge, which is how do you get to the community leaders? And in order to do that, there needs to be kind of almost a little bit of a restructuring of the response in a way, so they can see that get the resources, so they're able to actually engage in the response. Yes, Zina.
Sorry, can I sit down?
Yes, yes.
I'm thinking of Imam. In the communities in Sierra Leone, Yale, I don't hear about, I want to call it religious, I mean spiritual or non-earthly contacts. Have they got churches or missions or are they Muslims? What is the background, regardless of the Ebola outbreak, that influences people in these communities?
Okay,
Thank you.
thank you.
When we come to the spiritual leaders, Muslims, Christians, others, they really play an important role today in Liberia, Sierra Leone, and Guinea, because the people trust their spiritual leaders more than the politicians. Because of myself from Côte d'Ivoire, I experienced that for sure. Because the leadership, especially the government, don't care about the citizens of our countries. So in case like that, they would rather go to their spiritual leader because the spiritual leader is with them on a daily basis. Marriage, baby name ceremony, death, and everything. So they trust imams, they trust pastors, reverends more than the politicians because they know that if I go to my pastor or my imam, he will advise me at least. So therefore the imams today really are playing a big role, even here in New York. The Council of African Imams, now we are working with the health department, with the mayor office, Harlem Hospital, Bellevue Hospital, African Community Service here, and even many of agencies. So our next events are coming. We will do it with the Harlem Hospital. We're doing it again, town hall meeting, because we did one at the mosque, and that was a successful one. Now that the people are asking me if we can follow up, so we're gonna do that. But my message here today for health department, they are traumatizing our children. How? Because the fever, if my child has a fever, and I took her or took him to the hospital, before they do anything, he got Ebola or she got Ebola. And finally, after the test, they said, no, he's free of Ebola. And the child, believe me, he will grow up with that in his mind. They need to stop traumatizing our children. That's why today, as parents in the African community, they're afraid to bring their children to the hospital. Because they will be seen in the media, newspaper, television, that your son has, Ebola, before they do anything. So that's my message to you, Deputy Commissioner, please send that message out before they do everything. When we bring our children, test them first before you give the result out. Because in case of the the child in Bronx here, that was the case. Because it's the parents are from Guinea, and the child has fever, they took him to the hospital, Ebola. Now finally, a couple of days later, they said, no, it's Ebola free. But this young man is living today in fear. The parents, the same thing, because next time I don't think they will bring him to the hospital because of this stigmatization. So we need to stop that. Otherwise, the imams, the spiritual leaders are really doing an important role by helping people today.
Great. Well, thank you. And I think that's a message to the Department of Health, maybe, too. I think it's interesting because we're seeing almost similar to what's being seen on the ground in the affected countries. People are afraid. We don't want to happen the same thing of people fearing to seek health care. Yes, of course. Jay.
I'm very sensitive to that, and this is actually, I have no solution for this. Just to use the example that the Imam raises, by the time this child was being transported to the hospital, the whole street was lined with reporters and media, and the family that was in the home we were talking to them basically nonstop. We were trying to get them out of there safely so that they didn't have to be fear for their lives too. We're operating in an environment, particularly in New York City, where every movement that people make is observed. At any time anybody dons personal protective equipment, even if they do it in a way that's supportive and safe for that patient,